Thank you very much. أهلا وسهلا بيكم مرة تانية. هل كل الكاتاراكت زي بعض؟ لا. الجلسة دي بعنوان Cataract in Special Situations. Cataract in Special Situations لأن كل كاتاراكت تختلف عن التانية. أنا مؤمن بمبدأ مهم جدا في حياتي، إن تذاكر تنجح. يعني إيه؟ يعني لو ذاكرت الحالة قبل ما تدخل عليها وعارف الهازارد بتاعتها هتؤدي بصورة أفضل. Cataract is pseudo-exfoliative syndrome. It is the same. It should be with a success rate, as we have told in the first lecture, between 95 and 98%. The pseudo-exfoliative syndrome may be less. Why? To start with, what is pseudo-exfoliative syndrome? It is an age-related systemic syndrome. Systemic means that it is present in the eye, present in the liver, it is present in the spleen. It is found everywhere. Everywhere. It's a basement membrane disease essentially. Usually it's present in older than 50 years of old, but this is not the only situation. With age, you will find pseudo-exfoliative syndrome more and more. This does not mean that anybody who is examining a person who is 50 years doesn't found pseudo-exfoliative syndrome. After 10 years, he may found this disease. Every time you are examining your patient, you should examine for pseudo-exfoliative syndrome. The incidence is variable. In Japan, where the statistics are very critical and very accurate, it's 0.2% only of the Japanese having pseudo-exfoliative syndrome. It is about 20% in the Scandinavian, دول النرويج والسويد والكلام ده. مش عارفين لغايه دلوقتي ليه، لكن there is racial influence. في الدول العربيه موجوده بكثافه. جمهوريه مصر العربيه مفيش اسبوع بيعدي غير لما نعمل حالتين 3 4 pseudo-exfoliative syndrome. And it doubles every 10 years of age. It is first reported من 1917 و age related، وما بتحصلش قبل سن ال 40، وفي الريس هنا بيفرق جدا من حاله للتانيه. prevalence في الدول، مش كل الدول عامله ريبورتنج للإنسيدنس فيها. انا لقيت اقرب حاجه لهنا هي ايران. فيها نسبه حوالي 13 او 18%. العراق فيها قد ايه معرفش. افريقيا فيه 4 دول ريبورتنج، مصر ريبورتنج حوالي مثلا 15%. related to glaucoma, yes, it is almost present in 20% at diagnosis، وموجوده في about 50%. خلي بالكم with age الانسيدنس بتزيد. 5 yearly chance of acquiring glaucoma within 5 years and 15% chance in 10 years. يعني the more the years are passing, the more the glaucoma is there in pseudo-exfoliative syndrome. The problem that there is no symptoms, it's only cataract, and maybe not cataract also. We are finding pseudo-exfoliative syndrome in cases without cataract. Slit lamp examination, we will find this white flecks at the edge of the pupil, and you will find the transillumination defects which is around the pupillary edge, and there is poor pupillary dilatation which add to the difficulty of the surgery. You should measure the IOP in every case and do gonioscopy to check for trabecular meshwork if it is open or closed and the flecks are present in trabecular meshwork, and you should do a dilated examination for the fundus to evaluate the optic nerve. You should do also genetic test for the single mutation in the LOXL1 chromosome, and check for homocysteine level in the tear film and plasma. If high, there is more risk of cardiovascular disease. Remember, it is a systemic disease rather than a local in the eye also only. You should differentiate it from true exfoliation, which is really rare, and you should also differentiate it from trabecular meshwork hyperpigmentation. That's the pigment dispersion syndrome, in which in this picture there is this sort of transillumination here in the mid periphery, and this is very characteristic of pigment dispersion syndrome. Also, herpetic affection may give such picture. Prepare yourself well, and if you prepare yourself well, the results are good. Do the surgery early rather than late. Why? Because before the progression of the disease and subluxation will occur. Hints and tips during surgery: use high cohesive viscoelastic But remember, don't overinflate. Why? Remember that the nodules are somewhat weak, and you may injure the nodules by your viscoelastic. Pupillary management, all use the tools. Maybe Dr. Tawfiq will present for us the tools. I like very much the minute sphincterotomies. I am doing it a lot, and the results are very good in my hands. Also, you can do pupillary dilators and iris retractors. You may use it during surgery. The capsulorhexis, do it a large one rather a small one, expecting a large nucleus, and also to minimize the manipulation of the nucleus during your surgery and to avoid post-operative capsular phimosis. It is extremely important to do the hydrosection in a very proper manner. Don't begin your surgery before the proper hydrosection and the proper rotation of the nucleus. This is the golden rule in all my cases. Prepare micro hooks, not only for the pupil, but here I am using it to fix the edge of the capsule during my phaco. Prepare the endocapsular CTR, and I am postponing the CTR as far as it is safe. يعني هل نعملها بدري ولا متأخر؟ أنا بالنسبة لي المبدأ متأخر قدر ما يمكن. لما بحطها بدري it will interfere with the cortical removal. Any technique, I have used the stop and shop for almost the beginning of my 8 years. يعني ابتديت الفيكو 1999 وبعد كده قلبت على ستوب اند شوب، قلبت على ديفايد اند كونكر لغايه دلوقتي. يعني انا بقالي اكتر من 20 سنه او 25 سنه بشتغل فيكو. Gentle rotation with two instruments to minimize the affection of the zonules and keep the bottle low in order to also to protect the zonules. Always remove the cortex tangentially rather than centripetally. Why? To protect also the zonules. IOL choice, put in avoid hydrophilic IOLs. I don't like personally hydrophilic IOLs. In over 99% of my cases, I am using hydrophobic IOLs to prevent capsular phimosis, and they are better in the vision and optical quality. If the bag is compromised, also 3-piece hydrophobic IOL is better than hydrophilic IOLs. Visco removal, you should remove all the visco because these are compromised and there is glaucoma, and you should not allow post-operative spikes of intraocular pressure. And this is the conclusion. These are all the difficulties encountered during cataract in Pseudo-Exfoliation syndrome. Poor pupillary dilatation, zonular weakness, maybe subluxation of the lens. Posterior capsular tears are more common in such disease. Vitreous loss due to posterior capsular tear. Long post-operative inflammation more than the usual. Glaucoma is present in 20% of cases to start with, but may reach 50%, and you should manage. Late capsular phimosis is happening in some of the cases if you don't use the proper IOL, and late IOL bag dislocation is found in about 8% of cases, and in my cases I am finding it because I have started early the phacoemulsification, and nowadays more and more are coming with such complications. I thank you very much.